but as of August 20th, UAB Hospital was caring for 39 unvaccinated pregnant women. Of those, 10 were in the ICU and 7 were on ventilators. As I said, this was as of August 20th, and we are working to get updated numbers for the rest of August. So, Dr. Williams, would you like to start and give us a few kind of opening remarks?
Absolutely, and thanks everybody for joining. I think we have seen quite the increase in the number of pregnant patients we have seen affected by COVID hospitalized here at UAB over the course of the last month. So over the course of August, across our inpatient and our outpatient settings, we've had 65 pregnant women that have tested positive for COVID, and that is almost twice the high that we had back in July of 2020, where we only saw 34 women. So almost twice as many pregnant women that we've seen across our system in the past month. And we can really attribute that to the higher spread of the Delta variant that we are seeing. So along with the increased severity of COVID that we've seen in our pregnant patients and new data about the safety of the vaccination, the CDC has updated the recommendation that all women or people that are pregnant, breastfeeding, or even considering becoming pregnant get the COVID vaccine. And that comes from a combination of the safety data that we've now been able to analyze from that first cohort of women in the V-Safe program where they were reporting on any adverse events from their vaccination that showed that there were no increased risks as far as pregnancy outcomes, miscarriage rates. They specifically looked at women that were vaccinated in the first 20 weeks of pregnancy and saw no change in miscarriage rates among those women, as well as more data about the severity of COVID in pregnancy. And another recent study showed an almost 60% increase in the rate of preterm birth among pregnant women that are affected with COVID. So all the data we have is really showing that the benefits of vaccination far outweigh the potential risk. And so we are encouraging all of our pregnant patients to get vaccinated. Unfortunately, the numbers of vaccination are still quite low in our pregnant population. Less than 25% of pregnant women across the nation have received at least one dose. Those numbers are even lower in African Americans that are only about 10%. So we're really encouraging all of our pregnant patients to speak to their healthcare providers, get the information that they need, but we are strongly recommending that they get vaccinated.
All right, thank you. Dr. Dion, would you like to kind of let everybody know what we're seeing in Alabama with the Delta variant?
Absolutely. So we all have been living through this together. So you know this already, but I just wanted to update you on where we've come in Alabama. This is a state profile just from a few days ago. So you can see we're in the midst of this surge after we all thought we were nearing the end, May and June, really happy to have a vaccine available. We've seen this sudden increase over the past 2 months, and this is the increase caused by the Delta variant. The bottom graph shows you the positivity rate of all the PCR tests that have been done among people in Alabama. We ideally want to have a positivity rate that's less than 5%, which is where we were in May, and a rapid increase to 25%, with a decrease recently to about 20 to 22%. So this means there's really high levels of community transmission. So no matter where you live in Alabama, your likelihood of coming across COVID-19 today and next month is unfortunately still quite high. This gives you the status report, and this is data from ADPH that's submitted to CDC, showing you that high level, that bright red bar, high transmission for all of us here. And part of that is because of the low vaccination rate, 38% of our population, the lowest vaccination rate of all the US states, as I know you know. And the bottom says that when we sequence these variants, 95% of them are Delta variant. So the Alpha has been completely replaced by Delta. And I think that's really nicely shown in this data from CDC. So the blue is the B117, which is the older variant, completely replaced by the golden colored B1617.2. This new variant is incredibly transmissible, and it really spread across the world like wildfire. One of the big reasons why we're seeing differences in the hospital today compared to the surge we had in December is the age range of the people who are coming down with COVID in Alabama. You can see the largest proportion is 25 to 49-year-olds, whereas in December, it was mostly people above the age of 65. And that difference is that most people above 65 have been vaccinated, and we still have too many between 25 and 49 who have not been vaccinated. This includes pregnant women, but also women who may be pregnant in the next year or two, and their partners, their families, their children. This is all contributing to the community spread, unfortunately. I wanted to show you this snapshot because I think it shows nicely the percentage of the population vaccinated by county. If you sort of draw a diagonal line through Alabama, you see that the western half of the state has higher vaccination rates, and the NAT positivity, or where the infection is circulating in the highest rates, is the eastern half of the state, where our vaccination rates tend to be lower. This is not an anomaly. We know that in states that have high vaccination rates, their hospitalization rates, their death rates are lower. So this is something we can all take action and try to become more like those dark counties there on the left in our state. Dr. Williams mentioned this. This shows you the very slow increase, but increase over time in the number of pregnant women nationally who've accepted COVID-19 vaccination. Unfortunately, at 24%, we still have a long ways to go to where we'd like to be. And a lot of that is why we're doing this session with you all today, to answer some questions and get the information out there. So just to tell you a bit about what we know, remember, Delta variant we have known about for 2 months. So our data is really new. We're just beginning to understand. What we can say is that higher viral loads are being seen in people who have Delta compared to the Alpha variant. We're also seeing that people with Delta have a longer period of viral shedding. So instead of shedding for 5 days, they can shed for 7, 8, 9 days. That leads to more transmissions. The good news is that our currently available vaccines in the US are still effective against the Delta variant. So we still have a good level of protection. It may not be the case for future variants, and these will continue to emerge as long as we have widespread transmission. But the vaccines we have now do work against Delta, and we have that data. There's a question in the medical field and in epidemiology about whether or not the Delta variant leads to severe outcomes. We know that the more a variant transmits, the more people are going to get sick. But it looks like Delta is particularly dangerous in terms of the severe disease. A new study just published last week from the UK showed twofold increase in hospitalization with the Delta variant compared to the Alpha variant. And we're looking at this data at UAB, and our pregnant women, like Dr. Williams was mentioning, we are seeing that the women who were admitted with Delta variant have much higher admission to the ICU, ventilation rates, and their infants have more severe outcomes compared to the older variants of COVID-19. So this is really a call to action and why we're so concerned and so worried about what we're seeing today in these weeks. I will leave this for the question and answer if anybody wants to hear about monoclonal antibody therapy, and then pass this off to the next person.
All right, thank you. And before I pass it off to Dr. Grayson for her opening remarks, I just want to remind y'all that after Dr. Grayson finishes, we will start taking some questions. So if you have any, feel free to drop them in the Q&A box. Dr. Grayson, would you like to give your remarks?
Yes, thanks. So when COVID came around and kind of hit the United States in March of 2020, I was not currently pregnant at the time, but I became pregnant in the late summer, early fall, and was very concerned about what the risk would look like to me if I were to come in contact with COVID. One, my job certainly put me at risk because I do aerosolizing airway procedures both in the clinic and in the operating room. And while we were testing patients for COVID, we were certainly seeing urgent issues that had to be taken care of regardless of COVID status. And when the vaccine came out, there was a lot of question about whether or not pregnant women would be allowed to take the vaccine, given that they were not included in the original studies. And this is really common, but vaccines are not typically tested on pregnant women during their times that they're being created. It's not until very much later that that kind of data ends up being able to come out. And so I was hopeful that I would be able to take it. And I watched the FDA trial hearings when they came on particularly Pfizer, because that was the first trial that they had. And even though the study, people who led the study asked for the patients to refrain from getting pregnant and use effective birth control, there were patients within the study population who ended up becoming pregnant. And at the time of that FDA hearing, all of the patients in the vaccine group who had become pregnant were still pregnant. And that information was really helpful for me as I was trying to make decisions about what I was going to do. And in particular, we knew then that COVID could be riskier for pregnant women. We certainly have far more proof of that now, but those concerns were elevated. And that was really important to me as someone who also has another child at home. And so when it came down to making a decision about what to do, I had to look at it both as someone who was going to be put at risk at work for myself, but also for my child at home, my spouse at home who does not choose a life in medicine, and my unborn baby. And I ultimately decided to move forward with vaccination. I spoke with my OBGYN, who I trust very much, and she felt very strongly that I should move forward with vaccination. And so at 21 weeks pregnant, I received my first dose of Pfizer. It was a Friday, and it was the best Friday of my 34 years of life, with the exception of my wedding date and the birth of my children. This was really kind of a euphoric afternoon for me, because I was happy that I finally had something that I could do besides wearing PPE and trying to stay away from other people and social distance and stuff. I had a sore arm the next morning from the vaccine. I was still at that time participating in my CrossFit workouts outdoors by myself. And so I did my workout that morning without a problem. And then 3 weeks later, I got my second dose of my Pfizer vaccine. I had a mild headache after the second dose of the vaccine and a little bit of a sore arm, but that was really it. I was able to continue working. One of the weekends I was actually on call and I operated all weekend. So I was able to keep doing my normal things. The rest of my pregnancy went off without a hitch. I had no issues, no medical problems. I had a standard delivery with no complications, with the exception that there couldn't be as many people around in the hospital. And I now have a 4.5-month-old little boy who is happy and healthy and meeting every milestone and has some COVID antibodies, which is great given that we now have another surge. And one of the other, some of the data is looked at not just, placental transfer of antibodies, which was a really big deal for me to give him some additional protection, but also the question of what benefit breastfeeding might play in those as well. And so I am also breastfeeding to give him any additional protection that I can, in addition to all the other viruses that circulate out there that we know that breast milk and IgA antibodies can help with the prevention of. And so I know that it was a difficult decision for me to make in December of 2020, and we had this much data about pregnant women. This is a no-brainer at this point. This is the largest amount of information in a trial, essentially a real life trial of pregnant women who chose to get vaccinated. And that is where the proof really sits, is that we could look at all of those healthcare workers who decided to get vaccinated up front, despite the fact that they were pregnant. And they have seen that this is safe. And I have many friends who were not pregnant at that time who got vaccinated and have become pregnant since then. It's really important to me and probably all moms out there to make sure that I keep my children safe, but also that I am still present and be a part of their life. And I think we have seen all too well how risky COVID is in pregnancy, and it is not worth the risk to leaving your children. There are too many mothers who will never meet their babies because of COVID, and there are too many babies that will not meet their mom.
Thank you, Doctor. Thank you, Dr. Grayson. We're going to get into some of these questions. Dr. Williams, I know you talked about some patients in the hospitals, but can you tell us, what are you seeing with these patients, with pregnant women with severe COVID? And kind of a follow-up, are these patients who are in the hospital who are pregnant, are they maybe in the hospital because they have a pre-existing condition? So just kind of tell us what you're seeing.
Yeah, so the majority of these women that are being hospitalized, the ones that are being intubated, are coming in severe respiratory distress. So shortness of breath, of course, is something that is common to pregnancy, but these severe cases and hypoxia that we're seeing are the major reason why women are coming into the hospital. Unfortunately, when patients are intubated, are requiring more and more support to keep their body oxygenated, to keep their baby oxygenated. For many of these patients, there comes a point where we have to deliver the baby preterm in order to ultimately benefit the mom and the baby, because we're just not able to give them the support that they need, whether that's going on ECMO with the baby still inside the uterus. So we've had to do a lot of C-sections on these patients. Some of them can be planned, some of them are emergent at the bedside in the ICU, and that's just not a situation that anybody wants to be in. And as Dr. Dion mentioned, that has significant effects on the health of the babies that are being born preterm, and even some babies that are being affected by COVID as well. There are some patients that have comorbidities. I would say probably obesity is the most common one that we've seen, but there are also patients that have zero risk factors other than being pregnant that have ended up intubated in the ICU.
Thank you. And kind of going off of this, and this is probably a question for Dr. Williams and Dr. Dion. Let's just kind of address some of these, I guess, vaccine rumors that we're hearing. Vaccine might cause miscarriages. It could lead to infertility. Can y'all address these? I guess, Dr. Williams, if you want to start.
Sure. I think we really don't know where that rumor about the vaccine causing infertility came from. It's interesting because that was a rumor that I was hearing from patients the moment that this vaccine came out. And when you think about it, there's no way we would have known about infertility when this vaccine first came out. But we do have data now, as Dr. Grayson was mentioning, women that had got the vaccine initially, especially those healthcare workers that got it early on, that have become pregnant. There's been no decrease in pregnancy rates that we've seen. And then speaking to fertility as well, this is the largest data set we have looking at a vaccine, and specifically looking at women that were vaccinated before 20 weeks. We expect around a 15% rate of miscarriage at baseline, and that has been no different in women that have received the vaccine. So there is no attributed increased risk of miscarriage to the vaccine at all.
Dr. Dion, do you have anything to add?
Just to say that the technology that most people are getting is the mRNA vaccine, which is a new technology, although it's been developed over the past decades. And the good thing about this technology is that you are just inserting a portion of the spike protein, a portion of the code for the spike protein. So you're not putting a full virus in, or even an inactivated or a killed virus. It's really just the code so your body can recognize this virus when it comes in. The vaccine, after it's in your body, is really just in your muscle cells in your arm for a period of hours to days. It doesn't circulate widely or embed itself anywhere deep inside your tissue. That's not the way it works. It does not enter the nucleus. It does nothing with your own cellular genome, your own cellular DNA. So it's good just to put the facts out there to combat some of the misinformation. There's a lot of things on social media that are not true. So to back up what Dr. Williams said, talk to your doctor, talk to a healthcare professional, as opposed to someone that you've never heard of who has an interesting idea on Twitter.
Thank you. We're going to kind of stay on this topic of vaccines. Can we talk about if a pregnant mom has natural antibodies and immunity, say she had coronavirus before, is the vaccine still necessary for those people?
The vaccine is still recommended. I think that we're still learning a lot about the benefit and the duration of those antibodies with natural infection versus vaccination. But the recommendation is, as soon as you're feeling better, that you can have the COVID vaccine. Remember that when your body responds to the virus, it's making lots of antibodies against different parts of the viral particle. And the spike protein is exactly the neutralizing antibody that you need, and that's induced by the vaccine. So in the future, we will know more about how long that protection lasts and whether one is better than the other. Clearly now the vaccination is safe after you've had infection. One dose may be enough, as opposed to needing both doses. Those studies are ongoing too, but you shouldn't wait. You don't want to take the chance that maybe you had COVID, you're not sure because you didn't get a test. maybe you had mild COVID or you were asymptomatic and didn't have good antibodies. That's why we recommend everyone to get the vaccine, even if they think or they know that they already had COVID.
Thank you. And I know in our media Q&A from the other week, you talked about some studies that looked at, antibodies that were transmitted to the baby in pregnant women who got the vaccine. Can you talk a little bit about those studies and what they found?
Yeah, so these were really nicely done studies out of the Edlow lab in Boston. And what they did was they looked at women who got the one of the mRNA vaccines, and they looked in the woman's blood, and they looked in the baby's blood, and they looked to see if there was that transplacental passage that Dr. Grayson mentioned. Did the antibodies circulating in the mom end up getting to the baby? And they did. Obviously, it takes time for you to develop antibodies after the vaccine. So what they saw was women who had time during pregnancy to receive both doses, 3 or 4 weeks apart, depending on the vaccine, and then had a couple of weeks afterwards to develop that maximum antibody response. They were able to pass the highest levels of antibody off to their baby. So when you measure the baby's blood, you can see that spike protein antibody that was the same that was in the mom. We don't yet know how long that's going to last in the baby. So those are studies to look long-term to see what the durability is in the infant. But they also followed women who were breastfeeding to say, what about breast milk? Does the breast milk also pass antibodies? And it does. Sure enough, the breast milk was found to have antibodies, and that also was transmitted with breastfeeding to the infant. So really exciting news. We weren't sure that this was necessarily going to be the case. Most infections do lead to antibodies, and many of those are crossed through the placenta, but not all. So this is really another reason why, instead of waiting until post-delivery, you should be vaccinated before you're pregnant or during pregnancy to pass those antibodies. I think Dr. Grayson said it perfectly.
Thank you. And one more kind of vaccine questions. I know a hot topic in the news is boosters. Can you kind of give us an overview of what's recommended right now?
Yeah, so I mean, there's a few different categories. One is there's been discussion about a third vaccine dose for people who are immunocompromised. So let's get that out first. Those are people who are receiving cancer chemotherapy or had an organ transplant. Generally, these are not young, healthy, pregnant women. But if you fall under these immunocompromising categories, a third dose is recommended to try to get you protected. So this would be after you completed your series, at least 28 days, getting another dose. The question of booster doses for people who are immunocompetent or have good immune systems is still a very hot topic. There's been a lot in the press about recommending a booster dose after you've completed your series after 5 months, 6 months, 8 months. I can tell you that ACIP has just been talking about this in the past couple of days at their meeting in anticipation of making a national decision and national recommendations. And they did not explicitly come out and vote on this. So I think the likelihood is low that we're headed toward a recommendation very soon for booster doses for all of Americans. I think it may be in the future. Ideally, what I would like to see is a booster dose that's specific to the Delta variant. If we're going to boost people, I would love it to be the circulating variant and not the one that was circulating 6 months ago. But that needs to be developed and studied, and that we're not quite there yet. So stay tuned. But for today, for right now, the recommendation is not to that booster doses are not indicated.
Thank you. Dr. Williams, let's just talk. When you have a patient comes in that might be vaccine hesitant, what are kind of the key points that you provide her? And on top of that, is there, a safe trimester or the best trimester to get the vaccine?
I think the best trimester is the one that you're in. The sooner, the better. There have been you're going to get those benefits, and there is no difference in risk across trimesters. So, you don't want to wait to risk getting COVID. Unfortunately, I have had patients that had that appointment scheduled to get their vaccine, and they got exposed and they got sick before they were able to get that. So I would highly encourage as soon as you can to get it. As far as the conversations that I'm having in clinic, every single conversation that I have with a pregnant mom is about, what are the things that you're doing to make yourself healthy healthy, and to do the best things that you can for your baby. And the same conversation is true for talking about COVID vaccination. You know, have been very explicit the past months about what we've been seeing here and about just how sick some of our pregnant women have been, the women that have been intubated, and unfortunately the women that have lost their lives to this, and how, you know, like Dr. Grayson said, we don't want any mom, any family to be in that situation, to not be there for their baby. You know, I talk about the potential side effects. There are mild side effects from the COVID vaccine that, you know, I have experienced, others have experienced. So I do talk about those experiences as well, what they might expect. And I talk about it being a personal decision. And I do want to answer those questions. And I really encourage everybody to talk to their healthcare provider to get information that they can trust. We recommend other vaccines during pregnancy, and I feel like my patients trust me when I'm recommending those. And this is no different from that, and the other, you know, tests and medications and other things that we recommend as part of routine pregnancy care. I really want us to, you know, just think of this as now routine pregnancy care for the safety of mom, safety for baby.
Thank you. And then I guess this can be for Dr. Williams or Dr. Grayson. I know that pregnant women, they often face a lot of criticism every day and some unsolicited advice. What would y'all say to those patients who might be coming in and say they do want to get the vaccine, but either from their partner or their family or friends or just the community are feeling pressure not to?
Ignore them, simply. Just like you make any other decision in parenting. I mean, if you're becoming a mom and you have a partner, then you make those decisions often together. But at the end of the day, it is ultimately your health. And you are still the owner of your health, and making the decision that's best, one, for your livelihood and also for your child's, is ultimately up to you. And there will be some people that you cannot convince, and you should not spend your time or stress worrying about that. You make the best decision for you and you tune everybody else out. You also don't have to post it all over social media that you made that decision. That is your personal medical decision, and you can keep that private. And if you feel like someone is really going to make you incredibly uncomfortable, you know, physically, emotionally, or mentally, which is really important. I mean, you're growing another human, so you need to be taking care of yourself. Someone's going to do that. Just don't tell them. That's okay. You don't have to. You don't have to be the poster for vaccination and pregnancy. That's not your responsibility. Your responsibility is to take care of yourself and to take care of your baby.
Thank you. I know we are kind of getting close to our time limit. To our panelists, do you have about 5-10 more minutes to answer a few more questions? Awesome. So this one is for, I guess, either Dr. Dion or Dr. Williams. You know, why is it seeming like the Delta variant, like we're seeing more pregnant women in hospitals now with the Delta variant versus with earlier strains? And is there, you know, any fear of future variants that could be even more harmful for pregnant women?
I'm happy to take a crack at that. So the way I tried to show it with that data was to show you that what we're seeing now is high infection rates of the age group of people that get pregnant. So 18 to 25, 25 to 49. It's no longer people 65, 75, 85. That was the earlier wave. The current wave, because the vaccination rates are lower in these younger people, this incredibly infectious virus that's easily passes from person to person is infecting young people much, much more frequently. So that's what you're seeing. It's a manifestation of where the virus is spreading because of the lower vaccination rates in younger people. You know, we got the message out early on in COVID that being elderly is a risk factor, and that was heard loud and clear, and it was true. It's still true. But I think some young people got the message, oh, I'm not at risk of this. It's not going to, even if I get sick, I'm not really going to be sick. I can live my life and do what I want to do. And we are realizing that's not true anymore. So those messages we were giving at the beginning about focusing on the elderly population, I think some people are still holding on to that, and it's not the case. The question about the next variant is one that we are all worried about. And infectious disease, we know as these viruses circulate, they will continue to mutate. The next variant after Delta could be much worse, more transmittable, more serious outcomes. Nobody wants to see that. We all want to return to normality. We all want this to be over. That's another reason to push for vaccination, because the countries and the states and the regions that are vaccinated, it's like a wall for the virus. It can't get into your house or your community if enough people are vaccinated. We probably won't be able to reach population immunity anymore because of how infectious it is, but let's not even think about what the next variant will look like. Let's try to do what we can for the one that we know about right now.
Thank you. Dr. Williams, if say you were making this decision and you had a pro-con list trying to decide if you should get the vaccine or not, what would be your pros and your cons?
Yeah, I think pros would be, that this has been proven to protect against, COVID, protect against this Delta variant. I think when I'm, weighing the risk and the benefits, that's really what any decision for me comes down to. On the risk side, I have severe, risk of severe COVID, risk of intubation, risk of having a preterm delivery, if I were pregnant in this situation, risk of death. And those are all very serious, very real complications. And when I think about, the risk of the vaccine, maybe some arm soreness, maybe a fever, not feeling well for a couple of days, I now know and can feel confident that I'm not going to increase the risk of losing my pregnancy, of having any bad outcomes for my baby. So there's really very little, I think, on this other hand, that's going to outweigh the decision to get the vaccine. It's really, like I said, it's a no-brainer at this point. The scales are really tipped to the side of vaccination.
Thank you. All right, Dr. Dion, we are getting a few questions about monoclonal antibodies. So I know if you wanted to share what you had earlier.
Yes, happy to. Let's see if I can do it quickly. Great. So this shows you the SARS-CoV-2 virus, right? So you see the red circle, you see the genome inside, and you see the spike protein, which is the red surface protein on the virus. The monoclonal antibody therapy is the green, yellow-shaped antibodies, and this is created in a lab based on antibodies that human bodies made against this virus. We always track what our own immune system does because it's always really smart. They make these green antibodies so that they can fill those receptors on the virus. If those antibodies are in the way, the virus cannot attach or bind to the receptors on the human cell on the bottom. So imagine the cell in your nose or in your throat that the virus is trying to get into. The antibodies will prevent the virus from getting into that cell. We are recommending monoclonal antibody therapy based on studies that have shown for people with mild disease or moderate disease, this antibody therapy can prevent them from ending up with severe disease, can prevent hospitalization in as many as 70% of cases for people who are at risk. So severity is defined by people with underlying medical conditions, and pregnancy is considered one of the risk factors based on the data we now have for progression. The point I want to make is this is acting after the infection is already there. The vaccination is really the preferable option because prevention is always better than cure. But if you already have infection and you're sick within the first couple days of having symptoms and you're pregnant, this is something that may be offered to you that you can discuss with your physician. There's a lot of sites across Alabama, including here at UAB, where we can do monoclonal antibody therapy, intravenous or subcutaneous, a one-time injection that lasts over time to try to keep you out of the hospital. Again, not instead of vaccination, but in people, mostly people who have not been vaccinated, because the people who have been vaccinated tend to not progress to the severe disease. So that's just a very basic primer on how these monoclonal antibody therapies work, whether you're pregnant or not pregnant. Another caveat about this antibody therapy is you cannot be vaccinated within 90 days of completing this antibody therapy. So that is a 90-day window still that holds for vaccination after this.
Thank you. Okay, I have kind of one more question, and then I'm going to let everybody have their closing remarks. But we have a participant who's trying to help convince a family member to get vaccinated, and the family member ultimately is still not sure if there is enough data out there to really know the risk of getting the vaccine while pregnant, the risk to her, the risk to the unborn baby. just how can they be competent in this decision? So I guess Dr. Williams, if you have anything.
Yeah, I think that, the data we have now is based on several thousand pregnancies. I think this initial analysis from the VSafe information was almost 3,000 pregnant women that have been vaccinated. There have been more that have been included. We just haven't analyzed those pregnancies yet. So there will be more information to come. But I think that there is sufficient evidence at this point, given that we are, 9 months into this vaccination process, where we've seen pregnancies go full term. We've seen women that have gotten vaccinated before they were pregnant, gotten during pregnancy, that have had no adverse outcomes. So I think really trust the data. It's there for us. It's spelled out very clearly that there are no increased risk, and that we can feel confident this is a safe thing to do during pregnancy.
All right, thank you. And Dr. Williams, while you're already up, do you have any closing remarks?
Yeah, I mean, I think, we're really trying to just increase those vaccination rates, particularly in our pregnant women. That 24% is just really not where it needs to be. And I would, assuming that that rate is even lower here in Alabama, just knowing what we know about our statewide vaccination rates. We are only going to see more hospitalization, more ICU admissions in this population if we don't get those numbers up. So please speak to your healthcare providers, make that decision for yourself, and know that it is a safe thing for you and your baby to do.
Thank you. Dr. Dion?
I guess I just want to end with a perspective from the infectious disease side. We fight infections every single day in our job, and these infections can be hard to treat and challenging. So we need to be up to the task. We need to think about this as a battle. The virus is changing and giving us new variants. We have to up what we're doing. We have to recognize that the new infection and the new variants lead us to need new public health responses and to do things that maybe 6 months ago weren't necessary. Again, the only way out of this is not going to be done by an individual. It's all of us acting collectively and really trusting the science and making sure that we follow what the data says, so that we can protect one another. That's how we're going to get through this. And we will get through this. This will not last forever. This pandemic will not last forever. It just feels like it right now.
Thank you. And Dr. Grayson?
I'm going to put my white coat aside and just speak as a mom and a patient, technically, someone who was treated with the vaccine and has gone through pregnancy. Just please do the right thing for yourself. Please do the right thing for your baby. Don't be living with that regret that you didn't get vaccinated and you're sitting in the hospital preparing to be intubated and saying goodbye to your children for maybe a week or maybe forever. Just don't do it. It's not worth it.
Thank you. And thank you to all of our panelists for joining today and for everybody else who joined in. I know we couldn't get to all of the questions. I do encourage everyone to go to uab.edu/news. We have a lot of up-to-date COVID-19 information from our experts. We also had the pleasure to do a media Q&A about 2 weeks ago with the same panelists. The full recording is on our YouTube channel as well as some of our social media platforms. So if your question wasn't answered in this, they go into a little bit more detail in the other recordings. So I highly suggest looking at that as well. Thank you all for joining us, and thank you for everybody who spent time with us today. Have a great rest of your day.